So I will run through UltraSafe BBL, which is the missing link in safe gluteal fat grafting. This is a very busy slide, but it kind of summarizes the past 4 years of research that we in the United States have collectively done to figure out what's wrong with BBL and how to make it safe. The first is the paper from Cardenas Cabrera, the Mofid Teitelbaum paper, which did a 1 in 3,000 mortality. And then here is a video of the gluteal veins under the muscle using an endoscope, which I got permission from a patient when I did a redo BBL. But you can see how fragile these veins are. I had called.
Trying to have you room, and I'm getting no reception.
Excuse me. Can everyone hear me?
Yes.
Okay. So the gluteal veins are extremely fragile and thin, and they get up to about 9 millimeters in diameter over here. They don't tolerate stretch or fracture. And over here is a video of a CAT scan that we did in Colombia showing the very close proximity of the gluteal veins to the iliac vein. If you just flip this over, you see the underside of the piriformis. The gluteal veins are only 2.5 centimeters or 1 inch away from the iliac vein. So if you injure the gluteal veins, you're going to get a freeway exit onto the into the vena cava and into the right heart. We also did some really important dynamic cadaver studies. So these two studies are important. So in this study, we put fat just under the fascia, and we showed that the fat migrates through the muscle like a sieve. Muscle fibers do not protect you. It's the fascia that protects you. And these put traction on the veins, and all the fat ends up under the muscle. So any fat under the fascia is dangerous. And in this paper, which is its sister, subcutaneous migration, we put all the fat in the subcutaneous space and generated pressures up to 200 millimeters of mercury and showed that no fat went through the fascia into the deep subcutaneous subgluteal space. So the takeaway from all these research projects are the operation is unsafe when you put fat under the fascia. The operation is safe when you stay subcutaneous. And this, I think everybody would agree on. So the really key point here is, how do you know you're subcutaneous? How do you know that you're not inadvertently under the fascia? And the missing link here is a way to ensure that the cannula is above the fascia at all times. And as many cases as anyone has ever done, you know, I've done a bunch of cases and I could say, oh, I've done 4,000 BBLs and I've never gotten under the fat. It's like, so what? It's like saying I go through a traffic light 50 times and never been caught. All it takes is one time to inadvertently go under the fascia and you will get fat under the muscle. So this is an unmet clinical need. And so, you know, is ultrasound the gap? Is ultrasound the safety gap? And this is a good paper that was published by Ken Casco, and the senior author was Ricardo Rodriguez, who is a good friend of mine. And they did 15 patients with 2 surgeons, and they were trying to do essentially a Coleman technique where they were moving the cannula through the subcutaneous space and, you know, micro droplets, everything we learned from Sid Coleman. And it was virtually impossible to follow a moving cannula. And this paper did not get a lot of traction. And if you miss the cannula pass one time, you're not 100% safe. So if the cannula is moving and you have another surgeon following it, it's like those 3-legged races at picnics where, you know, people are trying to run at the same speed. It's just impossible. So what Pat Pasmino and I came up with, and Pat Pasmino should be credited and acknowledged for his efforts in ultrasound. I went down to watch Pat in the summer of 2021, and I noticed him doing ultrasound, and he said to me something really key. He said, one or the other of these has to not move. You either don't move the cannula or you don't move the ultrasound. And a light bulb went off in my head, and I said, he's keeping the ultrasound probe stationary and he's moving the cannula to it. And this kind of got us thinking about static insertion. So let's look at this as anatomy. We've got the dermis, the subcutaneous layer. We'll call the scarpas or the superficial fascia, but let's call it scarpas for a minute, the deep subcutaneous layer, and then the gluteal muscle and the gluteal fascia. This is key anatomy to understand. But when you look at it in live, it's really quite simple. Here's the cannula blowing up the fat, and you can see the fat in the deep subcutaneous space migrating really easily, and I don't move the cannula at all. This is stationary injection. We're exploiting the migration of fat. We're exploiting the fact that fat migrates. I've shown you in previous studies that fat migrates through muscle. Fat migrates like amazingly through this deep subcutaneous space. So we literally keep the cannula stationary, which is a total departure from everything you've learned from the Coleman technique. Now here's a split screen, just a quick split screen to show the ultrasound probe is here, the cannula is here. Once we see the basket cannula, you can see it right here in the deep subcutaneous space under the scarpus fascia, we start to deploy the fat and we step on a pedal. This is why it's probably not a great idea to be using a syringe, because when you use a syringe, you're going to be moving that cannula tip just a little bit and you could be under the fascia. But when you're using something like EVL and a roller pump, you can keep that cannula stationary and literally blow up the fat in the subcutaneous space. And all you have to do is blow it up and get it in the space. And once you start inserting the fat, you can see the cannula just over the fascia. The interesting thing is the preferred aesthetic space to be in is just over the gluteus muscle. And it's actually really close to the most dangerous space, which is just under the gluteus fascia. So you want to be right over the gluteus fascia. And you can see the fat, the ground glass appearance here, and you can see the fat migrating. And I'll move this along so that we can get through this slideshow. But what we do here is we fill it up so clinically we get to a clinically acceptable fill, and then we literally just move it over to a different space, and we finish that. And then when we finish these different compartments, we equalize the area. You see here how it's demarcated here, and it won't migrate any further than here. We move over to a different space, but you can see the fat's migrated to all these areas here. And what we do is we reinsert to a lateral space. You see it there. We assess the location of the cannula by ultrasound, and it's going to be right over the fascia. And then we go ahead and there's the cannula. We just deploy the fat again. And you see again another demarcation here. And then at the end, we just equalize it. So that's where we get this acronym SIGN: static insertion, migration, and equalization. And so here's some deductive reasoning. You can read this, but basically all the deaths from BBL revealed fat under the deep gluteal fascia at autopsy. There were no cases where fat was subcutaneous. So fat under the gluteal fascia is unsafe. Fat over the fascia is safe. Pulmonary fat embolism can be eliminated if we keep fat above the gluteal fascia. So here's the key. A cannula that's confirmed to be above the fascia by ultrasound that isn't moved is always above the gluteal fascia. So this is where the static part of it really comes in. And so we feel that SIGN will eliminate the cause of pulmonary fat embolism if it's performed correctly. SIGN is actually faster. So, the original ultrasound studies were like, oh, this is going to take forever, 2 surgeons following the cannula. Because the cannula is static and you're exploiting the migration of fat to fill the buttock, we actually looked at injection times, and SIGN is actually faster. It has higher flow rates. Why? Because you're not moving the cannula around. You're just filling and letting the fat migrate. And the reason this is so possible, and this is a key slide, and this is from Pat Pasmino, is that the deep subcutaneous fat layer has very little connective tissue, and it allows the migration of fat almost as a semi-solid, almost as a liquid. The fat will literally migrate under this compartment, under this fascial compartment, and it will fill it like a subfascial implant. So this is an interesting slide. Here's me. You see the demarcation here. It's a clear demarcation. And it started me thinking like the compartments in the gut. Someone needs to mute the microphone. I'm hearing a lot of, thank you. You see this demarcation here? This is a BBL patient that I saw, and I'm sure Ash has seen this plenty of times, but something's happening. Like the fat is migrating here, but it's stopping. So Jeff Kenkel and Pat Pasmino and I thought about compartments, and we did it with Joel Pessa, who did the original fat compartment paper with Rod Rorick, and Pat Pasmino and a couple of the fellows, Gianfranco and Samir. And what we showed was that there are definitely compartments in the deep gluteal fascia that limit the migration. So there's migration, but then there's a demarcation. That's why you have to equalize at the end. So that paper's out. It's a really interesting paper. You can take a look at that. So to summarize, the three major recommendations we made was, one, if you're going to do this operation, even if you've done it thousands of times, you probably want to use ultrasound to make sure your cannula is above the gluteal fascia. Pat Pasmino is going to give a course at the ASPS meeting. I'm going to help him. He's going to show you how easy it is to be under the fascia and think you're over the fascia. I've seen him do that a few times. I know he's in the audience tonight. Hi, Pat. Shout out to you. Great work. The other thing that we recommended is a total of 3 BBLs a day to avoid fatigue and distraction. Fatigue and distraction is in the literature. If you operate on your birthday, you have a higher risk of mortality. If you operate at the end of the week, you have a higher risk of mortality. There's definitely evidence that if you're fatigued, there's a higher risk of mortality. A lot of the cases that we reviewed in Miami were done at the end of the week. In fact, the majority of them, it's not statistically significant, but we certainly don't want to wait for another 30 BBL deaths in Florida to make it statistically significant. Just like we didn't wait a year for people to have higher mortality who didn't wear gloves and masks when COVID hit. When you're dealing with the public health, you have to deal with insufficient information and make decisions with insufficient information that are in the best interest of the public. So if you have to err on the side of being conservative, you do so. The last recommendation, which I think is really important, is a single surgeon approach, where the same surgeon does the liposuction and the fat grafting. We see a lot of cases where there are surgeons who are going from room to room and injecting fat, and they're getting physician extenders to do the liposuction. And we think this creates distraction and a lack of awareness of which patient you're operating on, and can increase the risk of subfascial injection. So we think SIME is safer, better, and faster. And we think that the guidelines are pretty clear cut. So that's it. Thank you very much.
Thank you so much. So Dr. Ghavami, feel free to comment either on the paper, the presentation, or both.
Thank you. Dan, as usual, amazing work. Honestly, without Dan and a small group of colleagues of his that he's written papers with, studied all this safety, if it wasn't for him, and I don't think we'd have the UK freeing the ban, and I don't think we'd have a lot of the knowledge we have today. Dan and I have had a lot of side conversations at meetings, some of them sober, some of them not so sober, but we've exchanged a lot of ideas. And I'm glad that he had the time to put some of them to good use and expand on them and develop this terminology and essentially almost a whole sub-specialty within our field, body contouring. This paper is no exception. Jeff Kenkel and Dan both organize it very well. I think it's a must-read paper for anyone doing gluteal fat grafting, even if some of the work in here is theory, and we have to all, I'm here to kind of give a counterpoint. If I just shook my head and agreed with everything wholeheartedly, there'd be no point of a discussion. But, we're limited in that we can't really fully study what's going on in vivo as much. Ultrasound's the closest we're getting, so that's a huge step. So Pat, thank you for that too. But a lot of the studies on migration, a lot of this work was done on cadavers, and cadaver tissue, the muscle doesn't have turgor, the tissue's not hydrated. You can't simulate how the musculature, the fascia, the sitting, the movement in the OR, the blood pressure, all this truly works when you're putting fat in the tissues. I'll break down this paper a little bit, just starting with a few things. One of the centers of this paper, the key points that Dan makes, and he's made this a lot in lectures too, is surgeon fatigue. I wholeheartedly agree with this, and it was sad and disappointing to hear that the norm is to have multi-surgeons, sometimes non-board certified, coming and taking over, multi-rooms being run. I personally don't do more than what I call an S-curve or gluteal fat grafting. I don't do more than one per day when I'm in the OR. So that's how I counter that. So my thenar muscles don't fatigue. I don't fatigue. I'm still relatively young, but we're talking about all comers. There's surgeons in their 60s that have had 5 spine surgeries that are probably taking on gluteal fat grafting. For them, I think it's necessary to probably do the entire surgery with an EVL concept technique. However, and I've always made this point at meetings, when you produce a technique that makes it easier to put fat grafting in, where the feedback between you and the feedback of the tissue is a vibrating tool, and with the longer distance between you and the tissue, it's like using a huge long needle holder to suture a transdermal suture in the lower laterals of the nose. You're decreasing some of that accuracy as well. So you're putting between your brain, your tactile feedback, a vibrating tool, and then with that tool, that's separate from the actual cannula. So what I like to do is I still do a hybrid technique, and I know if Jeff Kenkel's on, he'll hate that. Dan's never liked that, but maybe I'm just lucky in the few thousand I've done since 2008 that I haven't had an issue, but I know the anatomy, I know the feedback, and I like to start off knowing the anatomy of that patient. And sometimes I get someone who's 6 feet tall and a Paris supermodel that has very little fat grafting, very little space, that I could find it very hard to do ultrasound with when there's no tissue space and buffer room for the ultrasound, between skin, subcutaneous fat. Your muscle fascia is right there. You don't have much deep fat. You're creating a new compartment. There are no compartments in patients like that. You're creating a pseudo neo-gluteal contour buttock. To do an ultrasound on somebody, you'd have to hydrate the tissue, which means you'll have to overexpand possibly the skin. And in that person, if you're doing a fat grafting volume, and I know they said less than 200, maybe you don't need to do certain things, but that number, I'd like to know where that came from. But when I talked to the coroner, she said volume doesn't matter as far as fat emboli. I think a lot of it's technique and anatomy once again. And if somebody is a novice at this, they don't have training, they don't know the anatomy, getting a vibrating cannula in your hand and injecting through a roller pump a lot easier. You can also a lot easier get into the wrong compartments. So number one, before any of this ultrasound, any of this stuff, is to know the anatomy, understand the tissue feedback. And it's like everything else we do in surgery. You don't overexpand the pocket when you put a breast implant in. You don't do too much of a capsulectomy and thin the skin out if you don't have to. You don't pull the mass too tight to cause perforations in it. And when you're doing a subsmass facelift, same thing with gluteal fat grafting. You don't overexpand, so that you don't coalesce the compartments, and you don't underexpand. And in certain situations where the buttock is small, the skin, tissue, fascia, the layers are within basically 2-3 centimeters of each other. To try to figure out a static way to inject fat in that person with an ultrasound machine, that would take me probably 3 months of training with my experience to figure out. So I think ultrasound's a really good first step, but in a lot of patients with a lot of surgeons, it may not be as effective. But I think we had to do something in response, and kudos to Pat and Dan to create something like that, which hopefully is one of the reasons why the ban was lifted and why in Florida we can still do this. But I think we definitely have a long way to go. And I think the whole surgeon fatigue thing, I think, is individuality. One of the images shown in the paper, for example, is a lure lock technique, bending. The first time I recall ever having a discussion with anyone about this, I spoke to Jeff Kenkel and Dan about this. And they both asked me, what do you think's going on, Ash? And I told them, I think that what's happening is, I called it ligamentous misguidance. These fat compartments have borders. And when you saw that stained paper with the different fat grafting stains, where you didn't see staining and where you saw borders were exactly the ligaments that I described in that paper. And that ligament, especially the lower pull one, is essentially a barrier that if you have either a lower lock or a tulip, or, I'm sorry to say, a microair vibrating cannula far away, and you don't know where you're angling, and you don't release the ligaments enough, and you don't create the proper balance between release of tissue and tissue that has turgor to give you feedback, you will be misguided by the ligament to go deep. You can use the stiffest cannula that has zero flexibility to it, if anyone's using a lock and buttock fat transfer, I mean, you're way behind the boat. But if you're using a system that's rigid, where if you're in the wrong place, there's no bending. It's pretty hard to bend, for example, a tulip cannula. If you're in the wrong place and you go misguided, it's not the cannula that's going to bend. It's the ligament that's going to force you to go deeper because you haven't released it. So it forces you to go here. You haven't broken up the ligament. There's a small perforation. There's essentially a roof that's preventing you from angling up. So you're getting ligamentous misguidance. There's no flexibility in the hub. The tulip, if it bends that much, it breaks. I've broken a few. So I think what I do right now is a kind of a reconciliation between, in a lot of these fat graftings, if it's a small volume one, I still do the manual system. Been doing that for years. When it's somebody who has areas that need a lot more expansion, it's a larger case, larger volumes, I go ahead and do a hybrid technique where after I know what the feedback is, I've gotten to know the patient. It's like when you do a SMAS facelift. When you do the right side, you're getting to know the SMAS where you release. The second side is half as fast, always. Or twice as fast. It's twice to 3 times as fast to do the other side in a facelift. Every facelift surgeon can tell you this, because you got to know the anatomy of that patient's face and SMAS and tissue. You know how much to pull, you know where to cut, where to release, you know exactly where the parotid ends, all of that. It's the same thing for me with buttock. I want that tissue feedback. I want it to be a little difficult. I want to know that I'm in the right space where it's not too easy, but it's not too hard. I know that I'm angled correctly. And I know that I've gone in with the vibrating basket and released between these. Once I know the tissue, 60% to 50% of the rest of the case, I do with a injection with the microair, Dan does. I just don't use a roller pump because I don't want to have as low of a viscosity. I don't want it to be overhydrated. I don't want it to be volume of fluid. I want it to be fat so I can reach my endpoints and avoid a blowout fracture of the compartments coalescing. So I know, Dan, in this paper, for some reason, the ligament paper wasn't referenced, but these compartment papers, these compartments you found, if you look at those dye studies, some of those borders correspond exactly to where the ligaments are. And I do think the ligament understanding and knowing anatomy, it's like saying facelifts teach subsmass, but not teach retaining ligaments, not teach where the fixed parotid ends. I think it's critical to include that, even though it wasn't included in this paper. I think it's important for everyone to understand those borders because that's a direct safety issue. And it's one of the reasons I don't think it's just luck. I think that's one reason I've been able to avoid getting in trouble doing thousands since 2007, 2008, when I started doing all this and figuring it out on my own. The other thing I'll say about fatigue is if someone's doing more than 2 in a day, and I know Dan does do a fair amount. So with the EVL technique, you're able to do more than a few in a day. I recommend when you're starting out to do no more than 1 in a day. To have 2 surgeons and 1 hold an ultrasound, as Dan said, is a little ridiculous. We need to figure out, probably improve the technology. Hopefully soon, in about 5 years, we'll have something directly connected to the cannula. The last thing I'll say, and then definitely this warrants a Q&A and discussion and a back and forth, is that there's a theory of the analysis of the instrumentation and all that, but once again, a lot of that is theory. So it makes sense on a Monday because probably some surgeons are hungover to be careful. But once again, that flexibility misguidance, the lower lock, those kind of things right now are 100%, cadaver study or not. You cannot use a lower lock. And I don't think you still have to use microair for the entire length of the surgery. I think you can do a hybrid technique like what I do as you get comfortable. And so instead of a roller pump, we're publishing this, it's not a huge deal, but I just cut the tubing, directly inject into the tubing so that it's the same quality of fat I have manually. So it's essentially almost a hybrid technique of manual, but it's being assisted by the vibration and the release towards the last half of the surgery. So that combination might help some of you too, if you think about it. But once again, a phenomenal paper, a very good review, extremely necessary. And I think some of these things about fatigue and about the flexibility misguidance. I think to think about it once again as anatomy and always go back to the drawing board, migration theory, how they get into the veins, all of these things that have been astutely researched by a thinker like Dan are critical, but we do have to take them with a grain of salt and know that these are cadaver studies. It's a little bit different than when you're doing a facelift, that you have static ligaments, you know where things are. You're not really, actually ligamentous release and knowing where not to go to get out of the greater auricular nerve injury or injuring the marginal mandibular is directly related to what you release when you're lifting, where you're going, where the ligaments are, where the borders are. There's a reason why this anatomy exists in the human body. It's to protect certain things. The reason the ligaments are tighter near the ischial tuberosity is because we need that area as a fulcrum, and we sit on it and we use as biped mammals. It's a very critical area to bring in the musculature to allow you to walk. So there's a reason those ligaments are there. They're protected. And it's an important thing to understand, in addition to now the compartments, which we all knew were going to be there too. So I'll just close it with that and just open to questions, I guess.
Well, thank you for so many great comments there. I think we'll get back to it during the Q&A. I just wanted to go to Dr. Hustak for her comments, and then we'll all reconvene.
Yeah, absolutely. I think, thank you so much to Vecchio and Ghavami and Pat Pasmino. I got a chance at the Breast and Body Symposium. Pat came down and fussed with the ultrasound with us in breast and buttocks and kind of taught a lot of us how to better use this technology. I think this most recent paper that we're discussing a little bit today, and then of course some of the task force recommendation, has really put some data to those recommendations that came out in Florida. I think a lot of us early on when those were released were like, oh my God, where's this coming from? So at least this is data that demonstrates some of those things you touched on: fatigue, the amount of cases, the end of the week, and some of those outliers like Monday and what those mean. Some of the early recommendations from the task force were things that we had already been doing at my practice here in Houston. We had done 4 basket cannulas. We had done roller pump for the last 8 years or so with about 3,500 BBL. So those were things we were already doing. What we weren't doing was ultrasound, particularly single injection. And so I think that was really interesting to us because, as Dr. Del Vecchio and others have alluded to, you don't know exactly where that tip of your cannula is. You may think you're the best surgeon in the whole wide world, but certainly a lot of us were getting off our planes. And so I think being able to see where you are, I think was of benefit. In San Diego, I was blessed to be on a panel with Ghavami and Del Vecchio and some others talking about this. And I think since I originally was on that panel, I've softened a bit more to this idea of single injection. It's very counterintuitive to what we originally were taught with a lot of Coleman techniques. I think some of my original trepidations was having to get a lot of new technology when I wasn't having problems. I think my second trepidation was this was such an early technique and we didn't have any long-term data. Was the fat grafting with adequate take? Some of those early studies with Awake where you knew where you were, they were injecting about 500, I think 35 or 38 cc's, and their reoperation rate was around 50% because they were having to put more in. So the question was, were patients happy with this? Were we having adequate takes where we weren't having to go reoperate 50% of the time to add more volume? I think, as we're kind of navigating this, that's kind of improved to some degree. My second problem with this ultrasound single incision was we're watching where it is, but then we take it off and then we vibrate it and distribute it. So the question was with that, are you scratching the fascia and was that fat moving to where you didn't want it to go? I think there's been some sense that demonstrate that's not the case. As long as you're not power grafting while nicking the fascia and getting intramuscular, you're probably okay. I can see since Dallas at that Breast and Body Symposium, I have been dabbling with ultrasound guidance, and at least in the last 8 weeks, I will say that I'm actually loving my results, which is why I'm softening. I'm still safe. I'm still doing all those things I did before, but I have been happy with my increased projection and that deep subcutaneous plane. I think now that I know that I'm there, I'm getting that better projection and I'm going a little more superficial for some of the shaping. But I do think a lot of Ghavami's comments on the ligaments and moving it to adequate fill, I think are spot on. And so I applaud all of those on the task force that have made these recommendations. I still think there's a bit of a slippery slope with having this be a standard of care, but I am certainly softening to the idea of using ultrasound to know where I am. And I am liking my results, and I do think my take is similar to what it was previously. And I'll stop my comments there.
Well, thank you so much for your comments. Let me just ask one question, because I know that there's a question that came up at our hospital and several other institutions across the country. Where are we right now? And this is for all three speakers. Where are we right now as far as what's required? Are surgeons required to use ultrasound? Are they irresponsible if they're not using ultrasound? Where are we in that continuum right now?
There's a mandate here in California.
Because it says very clearly,
It's
this
pretty
paper,
new, isn't it? Experimental right now. I mean, how can we recommend something that has not been widely tested in multiple situations?
Agreed. I think the task force language says should be. I think they stopped short of saying must be, but that's a very slippery slope. I agree, Ghavami.
And also, I mean, you got to be practical. I mean, to hold it steady in one state, I have trouble moving around. With my knowledge and my experience, I still have trouble reaching an aesthetic result in some of these tougher, thinner patients, which honestly are my favorite patients, the ones that, a little bit goes a long way in. I worry about, I don't know if you guys know what a blowout compartment fracture is, but it's something me and Dan talked about outside the podium and discussed, and we both agree it's definitely a phenomenon. We've seen it. He showed one. It's when the compartments coalesce, the deep and superficial coalesce into one because, surprise, surprise, the ligamentous borders between them were violated and the fascial connections were exploded essentially from either overfilling in one area, or back in the day when I got my few in the first, I was massaging, and I'm relatively strong, massaging them into shape, and I would really hear a pop. That pop is a superficial deep communication that naturally isn't there in the gluteal anatomy. And that's a really hard thing to fix, requires revision surgery. I worry that some of these surgeons, especially those that aren't experienced, are going to think that they're all good because they're doing ultrasound, they're in the right place. You got to be moving around, you got to be releasing ligaments, you got to be knowing what the tissue feedback is, you have to understand the anatomy, you have to know the body contour, and then to be holding ultrasound the entire time. I mean, maybe you can go hold it. If you're a novice, you don't know where you are, you hold it, go where you are. Okay, I'm in the right place. Let me stay here, do some work. I'm going to change planes, then I'll go check there again. I don't know what that's going to do to the case, how long it's going to add to the time, especially if you're not moving your cannula. If some of these people blow in a little bit too much in one area, we're going to get mini blowout compartment issues and contour irregularities and other issues. I mean, I think with the experienced injectors that have been doing this a lot, if they were to get together and learn from one master ultrasound surgeon of how to do it and put this together. I was never approached. I don't know how that works. I've never done ultrasound with any of this. I probably could figure it out, but I would need to be taught by an expert who's really good at that with multiple types of people's anatomy.
Dr. Vecchio, what are your thoughts on all of this? I think you're still muted.
Unmute.
Okay, you got me now?
Mm-hmm.
Well, I mean, it would be a huge impossible challenge to respond to every single point that some of the discussants made, but maybe I'll pick a few. Look, I was fat grafting breasts in 2005, and I had people come up in the aisles and tell me I was going to jail. Some of you were residents at the time, or maybe even before you were residents. So I'm not. This isn't my first rodeo where people get on and start saying, well, you know, it has all these issues, blah, blah, blah. Of course, it's new, and you'll have to figure it out for yourself, whether it works for you. And it's a departure from the Coleman technique. But, you know, I was a zealot at EVL, and I was grossly opposed to ultrasound because I thought it would take forever. which it did when you were doing it the way with Coleman technique. And it was only until we figured out that this subcutaneous deep layer is privileged with very little connective tissue that you could literally put the cannula in and not move it. And as much as it sounds repulsive to do, it works. And so I think that I'm not surprised that there are people who are concerned about slippery slopes. But I think with time and other people validating it and using it, they'll add some nuanced techniques to it and make it better. I don't think the SIME is going away. I think this is the missing link for fat grafting to the buttock. I think at your point about, a longer cannula and one that's vibrating, reducing proprioception is probably true. But when you can see the cannula with ultrasound, how important is that? Kristi, you're getting better projection. That's great. Everybody who does deep subcutaneous always says, I get better projection with less fat. And it's because it's kind of like you're getting the core volume projection similar to a submuscular implant. So everybody who does SIME says that. So that's really interesting to hear you say that. That's great. But I think that over time, people will improve it, put some nuanced subtleties to it. I think the SIME technique is really a breakthrough. And I'm not upset or concerned or surprised that people are critical of it because it's new and it definitely is a departure. But I'm excited about it because I think that it really is the way that we can make sure we're not under the fascia. And I think that we should be able to reduce the mortality of this operation using ultrasound. And Ash, you're a great surgeon. You're a master surgeon, and I've seen you operate and I've seen your results. And it wouldn't take you more than a day to figure this out. It's like riding a bicycle. And as soon as you did, you'll be writing papers about it in different patient subtypes. It's very simple to learn. And I mean, the last thing I want to say to you, Ash, on a personal level is when we did that compartment study, I actually have slides that I'll show you that have a G in the inner medial compartment, and we called it Ghavami's compartment. And I don't know how that got changed. So I'm going to actually write an erratum in that paper. Not only am I going to fix the spelling error that you outlined to me, I'm going to change the compartment because I literally named it the G compartment for Ghavami's compartment. And it's shocking me right here in public that was changed. So I want to acknowledge that.
Thank you. I actually didn't, to be fair, I actually haven't read the paper. So I didn't know about that until you told me about it, and I thought you were joking. But this isn't about me. What it's about is that, you and I have had so many conversations. I and Jeff Kenkel, Rod Rorick, me and Teitelbaum, outside of the panels in different areas, and we've brought our minds together on this. I don't have the time. If you ask me to be involved, other than looking over it and putting a few red lines, I don't see how much more I could get involved. I'm ridiculously busy and I could be publishing left and right. And now I have fellows, so I am little by little, but kudos to you, honestly, because the energy you put into this, how much you've done. If you didn't exist, I don't know where we'd be with this. But I do think it's important for people to just know that it's always good to go to the basics. Always go back to the basics and the ligaments. I didn't describe those ligaments. Those ligaments were all described before and have actual very anatomical names, especially the ischial tuberosity one. But I know based on doing thousands of these cases, which, by the way, it's interesting when people publish or people write or go on panels or on task force that don't do this surgery and they don't do it often. That's kind of odd to me because, you can't write a facelift safety paper and have not done at least 1,000 facelifts. So I think one of the key things is that the people that are doing this surgery a lot really do need to come together. And that's what's great about the majority of the people on the task force. me, Dan, Tino Mendieta, all of us were in the cadaver study thing in Miami with Peter Rubin. We did ultrasound, we did fluoroscopy, we had dyed fat, and there was an experienced injector in there who caused a compartment blowout with dyed fat, and there was also an injector experienced that injected submuscular and had dyed fat all around the sciatic nerve and the gluteal veins. And then later, Dan, you and I, Tino, and I think one other person, we tried our best under fluoroscopy to try to lacerate the vein and try to get at it, and we couldn't. That is a testament. We saw the vein on fluoro and we tried to lacerate it with a basket cannula, and we could not get the vein lacerated. It was blown up and hydrated with dye through the IV, right? What does that tell you about cadaver studies? If relatively strong, experienced injectors are trying to go lacerate a vein, even partial tear it with a basket cannula under fluoroscopy direct visualization, and can't in a cadaver, then how relevant can all these studies on cadavers and safety be other than extremely experienced, well-educated theory? So we honestly still don't fully know the answer. And I'm a little getting tired about it, seeing task force recommendations and all this stuff where they're bordering on mandates, because that's a dangerous slope. When you have a society behind it, then eventually a board, you're going to outlaw a procedure that in many people's hands has been safe for decades almost. And I understand this is a crisis that we have to figure out, but we also have to be realistic here and do it very judiciously and very carefully, because the language and all of these things matter. Studies that are omitted, discussions that are omitted, theories that are made and then turned into recommendations are a little bit dangerous. And especially when recommendations center on technology rather than anatomy, knowing tissue feedback, and all the safety issues that go with surgery that we've done for decades in all of plastic surgery to avoid getting into trouble. So, and every surgeon's different from the other. My colleague might fatigue from one case, his thenar muscles might cramp, but I can do a 3-hour S-curve and I don't feel anything in my hands yet at all. It's not about fatigue and thenar. It's about the fat gets slippery. And as you do the case, the hub of the static cannulas, because they're not lure lock, aren't attached well to the TUMI. So they start loosening. So you can't use two hands anymore. And you have to like figure it out. And that's when I switched to the more EVL concept now. And so I switched to that at that point. It's not because I'm fatigued or tired or I don't have this and that. I learned the tissue and I switched over to that. So everyone is allowed to do their own thing. I'm allowed to do it that way, and I'm allowed to not use ultrasound. And
yes, you are allowed to not use ultrasound. And I just want to interject here and make sure we're all aware of a paper that came out 20 years ago. And it was published in PRS, and it was practice advisory on liposuction. And it was Dennis Lynch and another plastic surgeon. And they set the guidelines for liposuction. At the time, the mortality for liposuction was about 1 in 3 to 5,000. And they came up with guidelines like 5,000 cc's of aspirate maximum, no more than 10 amps of epi, over 5 liters of aspirate, you have to stay overnight, over 10 liters of aspirate, you have to stay in an ICU. And believe it or not, these are still the metrics that we use in liposuction. And I went and spoke with one of the people who was on that panel, and they had a task force for liposuction. It was made up of about 50 people, and nobody could get consensus. There were too many opinions. So these two individuals came up with the guidelines. They weren't based on long-term studies, data. They were based on common sense. I asked one of them, I said, where'd you come up with a 5-liter number? And he said, 10 sounded too high, 2,500 sounded too low, 5,000 sounded just about right. So I guess my message to you, everybody, is this practice guideline isn't a mandate or standard of care, and it says it right in the paper. It's two individuals who come from very different areas of polarity in BBL. Jeff Kenkel and I chose Jeff, and Jeff and I did this paper together because we are not buddies and do the same operation. And Jeff doesn't even do BBL. His residents at UT Southwestern don't do BBL. I picked him because of that. And we came together and came up with these guidelines. They may not exist 5 years from now, but it's a best effort at having limited information. And lastly, I want to thank Dr. Nahai, and I want to thank Oxford Press for accepting the publication, because they are guidelines and they had to accept them as such.
Thank you. So I know before we go to Deniz for the audience poll questions, I know Dr. Pazmino is on and is willing to say a few words.
Thank you. Good evening. And thank you. Can everyone hear me?
Yes.
Terrific. Thank you. I learned so much from this terrific webinar. That was absolutely fantastic. And I think it's so important to hear the back and forth of the different perspectives. I felt that was really, really important. Just a few points that I would make is that, number one, there's been a focus for a long time now about the specific instruments that we use, whether it's a Luer lock, whether it's a 2 millimeter or 4 millimeter cannula. Our experience here in Miami, when we have examined the deaths at the morgue, we have found deaths with every single type of cannula, whether it's a very thin one, even with EVL. We have found deaths with EVL, we have found deaths with Luer lock, and what that has caused us to realize is that it is not the cannula tip, it is not the injection system. To do this procedure safely, the only thing that matters is where is the tip. That is the only thing that matters. And this can happen to very experienced or unexperienced surgeons. So the recommendation, the challenge that I would make to everyone is go ahead and use your favorite technique, put the cannula inside the tissue, and just use the ultrasound. You can even borrow one to see where the tip is. And once you start actually visualizing where the tip is, this procedure, in my experience, has been very humbling, because I do this procedure every single day. And many times, like Dr. Del Vecchio mentioned, I will put in my cannula and I trust my experience, but by verifying, I actually see that I'm in the muscle. So that's what's unique about ultrasound. It'll tell you when you're wrong. And there's no way of knowing otherwise. Otherwise, it's a completely blind procedure. The other point that I would make is that in this movement, it is not so much about technology versus anatomy. It's about using a new technology to finally see and appreciate the anatomy. Dr. Ghavami is completely right. And when he was talking about the blowout fracture, what happens is that one fascia has been violated, and all that beautiful fat in the deep subcutaneous compartment is going to the superficial compartment. And that's what creates the blowout fracture. And we have to give Dr. Ghavami credit for describing that. So my last point is that, just like Dr. Del Vecchio says, this can make you a faster BBL surgeon. When I perform this, I'm not as fast as Dr. Del Vecchio, but it typically takes me between 7 to 10 minutes per buttock when I use this. So it is not a slow procedure. It can make you faster, it can make you safer, because you can document that you are always above the deep gluteal fascia, which is the most important thing. But most important, and then this really touches on the point that Dr. Hustak made, and it's wonderful to hear that, is that this can make you a better surgeon, because these two different spaces are very distinct morphologically, histologically, and functionally. And when you put fat in the right space, you can get beautiful projection. And in the end, that is all that we want. We want a beautiful aesthetic result. So thank you very much for the opportunity to make a comment.
Well, thank you so much.
That's great,
All right.
Pat. Let me say one real quick thing. So maybe I'm not understanding. So is the recommendation in vivo in clinical practice to do the surgery, and then when you want to see where you are, put an ultrasound, confirm it, and then go ahead and do more surgery, and then confirm it again when you're questioned? Or is it to have ultrasound during the movements? Because in a lot of these patients, I can't wrap my head around keeping the cannula in one place and just putting a roller pump on. That's like against my religion to even think of not moving the entire time. That's how I do fillers. I'm always moving. I don't use a cannula technique. I'm always moving the needle, even if it's a 0.5 millimeter here, there, changing planes. so that I'm not where I don't want to be. Movement is the way to not be in the wrong place for too long.
Thank you. And that's an excellent point. And it's true. That's Dr. Ghavami really highlighted the paradigm shift of what Dr. Del Vecchio was talking about, that the main point of this, the technique sign, is that it's a static injection. It's a static injection of fat. And so what Dr. Ghavami said is that by moving, you can always confirm that you are in the right place. And what the paradigm shift here is that by visualizing the tip, that's how you confirm that you're in the right place. And so in the sign technique that we're describing, you go ahead and you make a bolus of fat, per se, in the first compartment that you want. And then you watch that fat migrate. And then once you're happy aesthetically with that migration, then you go to the next site and then you bolus again. So in the end, you have 3 to 5 different sites that are bolused. And after you're done with that, it'll look like a hill full of moguls. It'll have little bumps. And then you do the equalization. So then you use an active cannula to selectively release ligaments that Dr. Ghavami described, and to move the fat around. So the injection is static, but after the injection is in, you can equalize with a dynamic cannula.
So this is not unlike what I was recommending, which is you inject, confirm, except instead of ultrasound, I use experience and tissue feedback, because I didn't want it to be too easy or too hard. Then you go release, equalize, massage it out, whatever. Then you inject more. And throughout the case, you're kind of molding, injecting, but releasing in between. So you're basically confirming, injecting, releasing, coalescing, confirming, injecting, but you're doing it in different aliquots. So that's kind of an intermittent sequenced injection, confirmation, injection, confirmation, coalescing thing. That makes a lot more sense. I was under the impression we were supposed to be having an ultrasound on the buttock the entire time we're moving and trying to do this case. Technically, though, I could tell you guys, I mean, I know the experienced injectors here will understand this. When you have somebody that's, you know, some model or Instagram model or runway model that weighs, you know, is 5'5", that's not a runway model, as we all know. It could be a dancer, not ballet. But let's say 5'5", and then they have like 115 pounds of fat, and you're just trying to get a little bit of flank fat in that lower danger zone pole area where all those ligaments are so tight. You're releasing those tight ligaments. I've bolused those areas after I've released, bolused, released. I wouldn't say bolus, but I'm constantly moving. So
right.
When the space is really tight in a thin patient like that, where the skin, subcutaneous, ligamentous borders, deep fat, and fascia is like all within this much, how do you get ultrasound in there? Do you have to hydrate the tissue, take a look, put your cannula? Because for me, I can, when those patients, you can see your tip. You know exactly where your tip is because you're seeing it through the skin. The thinner patients that are worried, that people worry about going in the wrong place, those, your tip is right there under the skin, and you know it's angled up. You drop your hand, you do all the techniques I and Dan and others talked about, not using the lure lock. So those patients, I feel like ultrasound is not needed as much. To me, it sounds like ultrasound's needed more in those bigger volume cases where you get a little bit lost. There's fat in there, you don't know where you are, you're trying to create that final shape. Those are the times when I, even because of all these damn task force things, I get a little scared too. You know, at that time, maybe I'll use an ultrasound, but I'm going to have to be looking through a huge border, huge amount of fat that I added to get down to see where I am. So it'll be like a Jacques Cousteau kind of thing, but that makes a little more sense.
So we're a little short on time. I just wanted to go to Deniz to take it away, please.
Just to kind of round out the discussion, we usually end around 8 o'clock. So as expected, most of our audience members do perform BBLs, about 80% of us. And the ones who don't still cite safety concerns, lack of patient demand, or just not a lot of interest in performing the procedure. With regards to the first group of task force recommendations from 2017 to 2019, again, most of us have incorporated those recommendations, about 80%, with still a few of us not having incorporated those recommendations, which include just kind of the basic subcutaneous, using larger cannula, things like that. And then just to touch on the commentary by Dr. Louis Rio, he did mention at the end of his commentary that there are a lot of practitioners who are not board certified, who are kind of these BBL factories using mid-level providers for part of the procedure, and then they themselves doing part of it, who may or may not be a large part of the unsafe, more deadly BBL, especially in Florida and things like that. And he suggested having a long-term registry to kind of track and see the safety of this procedure. And most of our audience members actually agree that that would be a good thing to have. And I don't know how the discussants tonight feel about that, but I always think it's a great idea to track and see if it's our society, see if it's our board members, or if it's these cosmetic surgeons or people who are unqualified doing the procedure. So that's, and I don't think we have too many questions from the audience tonight. So thank you guys so much for everything. Dr. Hustak, Ghavami, Del Vecchio, thank you for being here. And hopefully we'll see you guys again soon.
Very important topic. Thank you, everyone. Awesome work, Dan, as always.
Dr. Del Vecchio, there is one question directed toward you that I wanted to be sure that we got to. And for all those who can't stay past the 9 p.m. slot, feel free to drop off. The question is, apologies. This question asker wants to ask about IVL and buttock physical therapy related to this procedure and post-op care.
I think you're muted again. We can't.
Dan, you're muted.
Oh,
There we go.
it's got nothing to do with safety, and just give me my email and I can talk to him. But it's not, it's just not relevant to the conversation. I really appreciate the back and forth. I appreciate everyone's comments. And I couldn't be more pleased. And I thank everybody for being critical and questioning, because that's how we make things better. So thank you, everybody.
Any last comments or questions from anyone before we close? All right. Well, thank you, Dr. Del Vecchio, Ghavami, and Hustak. We really appreciate your time tonight. Have a great night, everyone.
Okay.
Thank you.
Bye.
Bye.